Well, I think that the benefit of this CPX agent in the upfront treatment of these patients is really in patients with what we call secondary AML. AML that has arisen from a prior antecedent hematologic disorder or prior malignancy. This patient population traditionally has had very, very low response rates to 7 and 3, and we're not 100% sure why that is. The survival benefit that we saw with these patients was something that was real, that was maintained, that resulted in several months of prolonged overall survival. One would postulate that a liposomal formulation, which has better penetrance into the bone marrow and better pharmacokinetics, would translate into higher levels of toxicity, because these are cytotoxic chemotherapy agents. But very impressively, we did not see increased toxicity with those two, with the liposomal formulation. So CPX-351 actually was reported to have the same or even less toxicity than the parent compound. So I think the clinical benefit in these patients is real. I think that it's something that, as the abstract says, may lead to the new standard of care for the treatment of these secondary AML patients, which again would be one of the only improvements over 7 and 3 that we've seen over the last 4 decades.